the practicing pediatrician very easy. And also, we have to thank our convener of this clinical genetics, Prajna Rangnath madam. You have taken utmost interest and utmost taken care of the topics, and also inviting the national and international speakers onto this platform. And really, we appreciate your efforts, madam. Thank you so much, for Prajna Rangnath madam. You have done a great job. And coming to the Sunkoj Bhaskar sir, I request President to say a few words and start the program, sir, please.
Thank you, Dr. Sridhar. I think I'm not visible. There's some problem with video.
You are not visible, sir. Your camera is not safe.
Okay, doesn't matter. I'll talk now. I'm audible, isn't it?
Yeah, you can. Yeah, you are audible, sir, very much.
Okay, fine, fine. Namaskars, and I welcome our distinguished faculty, Professor Dr. V.H. Shankar and Professor Dr. Meena Agarwal, our our webinar series coordinator, Dr. Prajna Ranganath, our PATS President 2026, Dr. Vijay Kumar, and our Secretary, Dr. N. Sridhar, and all the other participants, and as well my team members of P. Thank you all for joining on time, and my apologies for the delay by 2 minutes or 3 minutes. And this is the fifth episode. This is the fifth episode. It's a record by itself. In the sense, until now in Telangana state, by IAP, no episode or no topic went on for 5 episodes successfully without fail. Despite being one of them was a festival, a big festival. Even on the day, we had festival, and as well we had this academic festival. Uh, and the interesting thing is, it's not the credit not doesn't go to PATS. The credit goes to our coordinator, Dr. Prajna Ranganath. She had prepared the program way back in July, August 2024. I once again repeat, she had prepared the program, the entire program, way back in July, August 2024. That was the passion, zeal, and that way we are lucky and we got the right person for the right thing. And another uniqueness about this program is every episode has a recap of the last episode. I mean, who had missed it for some reasons, or even those who had attended last time can recapitulate immediately what went on, and the sequence will be maintained after 4 weeks. So that is again uniqueness. And I thank Dr. Prajna Ranganath to accept our request to present a brief recap every time. So, and amazingly thankful to her to bringing eminent faculty members, eminent guest faculty, like last time we had Dr. Madhulika Kabre, then Dr. Shubha Padke, and I think Dr. Arora. So, so many things are happening, and this last session was really appreciated by many people on YouTube because it was truly a clinical genetics program, like an approach to a child with dysmorphic features. And this session, I'm sure Dr. V.S. Shankar is a professor of pediatrics and genetics from SAT Hospital in GMC, and as well Dr. Meena Agarwal, Professor Dr. Meena Agarwal, KEM Hospital from Pune. They will be presenting on this karyotype and fish, as well chromosomal, microsomal assay. So with these few words, I sincerely thank one and all for being with us for this program. I'm sure it's going to be very helpful to all of us. Thank you again, and over to Dr. Sridhar, our secretary.
Yeah, thank you. Thank you, sir. Thank you, sir. Your nice words. And I want to remind you, all the delegates, these webinars are available on the YouTube. At any your free time, you can go through the YouTube and see the topics, all the topics. The first topic, which was started with January 1st, January 5th, January, it is demystifying approach basics and beyond. And later, second webinar we have done on 2nd February, which was normal structure of a gene, definition and types, and genotype and phenotype. And third webinar is on 2nd March. We have done the recap of second episode and also genetic counseling based on patterns of inheritance. And today's very interesting topics, because we do write whenever we see the abnormal cases in practice and hospital, we do write the karyotyping and this fish and chromosomal microassay. So I think we do write, but we don't know the concept of what we are going to do. So I think our faculty, eminent faculty, Dr. Shankar Garu and also Dr. Meenal Agarwal Garu, will definitely throw more light on us, and it will definitely helpful for the practicing pediatrician. And next, I want to request Prajna Ranganath madam, please introduce the speakers and go for the topic, ma'am. Your platform is yours, please.
Excuse
Thank
me,
you so much.
Dr. Vijay Kumar is there.
Uh,
He made a few words.
yeah, sorry.
Dr. Vijay Kumar,
Okay. Sir, I
HOD.
acknowledge the presence of Dr. Vijay Kumar, sir. Sir, Dr. Vijay Kumar, sir, please, few words. President-elect, few words, sir, please.
He's the HOD of Neelufar Hospital.
Good morning, sir. Good morning, Bhaskar sir, Sridhar sir, Prajna madam. Sir, eager to hear the lecture, sir.
Yeah, thank you, sir. Ma'am, platform is yours, please.
Thank you, sir. So, good morning, everyone. To the fifth session in this webinar series on clinical genetics. And I'd like to thank Dr. Bhaskar sir, the entire PATS team, and all the dignitaries present today for this opportunity. And we have been discussing this every session, that it's extremely important for all pediatricians to know all the basic concepts of clinical genetics, because we do know that a lot of disorders pediatric age group have a genetic basis. So before we begin today's session, as per our usual pattern, we'll begin with a quick recap of what was discussed in the previous session. So the previous session was taken by Dr. Madhulika Kabra ma'am, a former professor and head of the Department of Pediatrics and Clinical Genetics at the All India Institute of Medical Sciences, Hyderabad. So, Madam had taken us through the various steps of how to clinically approach a child who presents with dysmorphism. So, I'll just do a quick recap of what Madam had discussed. So, we know that types of congenital anomalies include malformation, which is an intrinsic developmental defect where there is a primary error in morphogenesis. And here, the onset of this is from the period of organogenesis itself, and it can have varied etiology. All malformations need not be of genetic origin. You can have malformations arising from teratogenic exposures, and many of them have a multifactorial etiology. Deformations, on the other hand, are physical distortions of a normally developed structure. This most often involves musculoskeletal structures. Intrinsically, the structure would have been developing normally, but then usually in the latter half of gestation, because of mechanical forces such as oligohydramnios, compression of the limbs against the uterine wall, etc., the deformation starts to happen. One of the typical examples being a clubfoot deformity, the congenital talipes equinovarus deformity. Disruptions, on the other hand, are where the initial organ development is normal, but because of some vascular event or some mechanical event, the development gets disrupted. And this is usually because of intrauterine environmental causes, which could be, like we discussed, it could be infective causes, it could be vascular causes, it could be like an amniotic band sequence, and so on. And then dysplasia is where there is an abnormal tissue organization. So classic examples being skeletal dysplasias and others. So these congenital anomalies can either occur in isolation, or they can occur in association with other anomalies, in which case we call them syndrome, association, sequence, and so on. So, presence of any one anomaly should always prompt the search for other associated major and minor anomalies. And therefore, we have to remember that in any child in whom we see an external dysmorphism, an external malformation, we have to do a thorough internal evaluation for internal visceral also, which would include doing imaging studies like 2D echo, ultrasound abdomen, hearing evaluation, a complete ophthalmology evaluation, and so on. Syndromes are a composite pattern of two or more anomalies with a known etiology. One of the classic examples being Down syndrome, where you know that you have this specific pattern of dysmorphism anomalies, and all of them are caused by abnormalities involving chromosome 21. Associations, on the other hand, are non-random occurrence of two or more anomalies without a known etiology. And here, this common example given usually. For example, we have this child who underwent surgery for imperforateness, and her 2D echo showed an atrial septal defect. Ultrasound abdomen showed an absent left kidney. Of course, all of them may not have all components of the association. Generally, they tend to have two or three or more of the anomalies in the association, but for most of them, the underlying basis remains unknown. Sequence, on the other hand, is a series of events which results from primary event. So this primary event initiates a cascade of events that result in multiple secondary anomalies. For example, you may have a renal anomaly or bilateral renal agenesis, which results in severe oligohydramnios because of decreased fetal urine production. That in turn will lead on to compressive effects to your quarter facies, which typically involves flattened facies with a flattened nose, deformed low set ears, pulmonary hypoplasia, positional limb defects, and so on. And then, therefore, whenever we are approaching a child with dysmorphism, we have to remember that we have to take a detailed history, including the prenatal, perinatal, neonatal, developmental history, a minimum 3-generation pedigree, along with a detailed family history. All the anthropometric measurements have to be taken, and they have to be compared with the standard norms for age and gender. You have to do a thorough head-to-toe examination to pick up all the dysmorphic features in the child, a detailed systemic examination to look for all the systemic abnormalities. And wherever possible, please also examine the parents and other family members who are available there for consultation for similar or related features, because some of the so-called dysmorphism may actually be, especially some of the facial features, may actually be normal for some families. And some of these abnormalities may be there in other family members as well. Other family members may be having the same genetic syndrome, the same genetic dysmorphic syndrome, and therefore it's important to identify that by doing the examination of the family members who are available. And I already mentioned the importance of doing 2D echography, echocardiography, ultrasound abdomen, skeletal radiographs, and neuroimaging wherever relevant. Other ancillary lab, including the appropriate hematological investigations, biochem investigations, etc., as relevant to the case. And we have a lot of resources which are available which help us with this. So this is a free article from the American Journal of Medical Genetics, which actually gives you all the elements of all the elements of morphology, and helps you kind of identify what are the different dysmorphic features, giving the definitions for those features, and also pictorial representations of each of those dysmorphic features. We have a lot of online resources also. So the online Mendelian Inheritance in Man database, which lists almost all the known genetic disorders, including the dysmorphic syndromes. So this is freely available. This is not a paid database. You have some paid databases as well, such as OMIM and POSSUM. Also have some resources which are partly free, and if you want to go to the more advanced aspects of those resources, you may have to have a subscription for that. So one such example of resource is Face2Gene, which is very helpful in the clinic you can upload the photograph of the child and add in some other relevant details like the anthropometric measurements and other relevant clinical details, and it gives you a set of possible differentials. And of course, once you have a specific set of possibilities in mind, you can go ahead with confirmation by relevant genetic testing, which could be either a cytogenetic test or a molecular cytogenetic test or a molecular genetic test. Today, will be talking to us about the cytogenetic tests and the molecular cytogenetic tests. But as was emphasized in the previous session, particularly when we are thinking of genetic syndromes, it is important to do the relevant testing, confirm the diagnosis, and then only go ahead with the counseling, the management, the prognosis, and all that. Please do not label a child with a query diagnosis because then, in many cases, that may not be correct. So, with that recap, we'll now move on to today's session. We are very happy to have two very eminent speakers with us today. And our first speaker is Dr. Shankar VH. Shankar sir is professor in the Department of Medical Genetics. He is working at SAT Hospital and Government Medical College, Thiruvananthapuram. He is a pediatrician by basic training, and then he has done his super specialization DM in medical genetics from Sanjay Gandhi PGI. He has over 26 years of teaching experience and also has been an examiner and PhD guide for several students. He has a lot of important uh, this thing to his credit. He has worked with WHO in the National Polio Surveillance Project. He is in charge of the state-of-the-art genetic laboratory in the government sector in Trivandrum. He is nodal officer for the Center of Excellence for Rare Diseases at GMC Trivandrum. He's also instrumental in starting the medical genetics department in the state, and he's a member level committees related to genetics. He's a PI of several projects funded by ICMR, DHR, DBT, and so on. He has more than 60 publications in national and international journals and more than 10 textbook chapters, including the IAP textbook, to his credit. He's also a reviewer for several international, and he has worked in various capacities at the district, state, and national level in the Indian Academy of Pediatrics. He's also one of the founder members and treasurers of SIMG. We are very happy to have you today with us, sir, and we look forward to your session. Over to you, sir. Thank you so much for accepting our invitation.
Thank you, Prachna. Thank you, Prachna, for
Sir.
giving me the opportunity to talk in this August program of IAP Telangana. I think my slides are visible.
Yes.
Okay.
Can you
So,
please?
and
Yes.
I'm also congratulating the IAP Telangana for taking the important area of genetics to create awareness among pediatricians and other clinicians for the smooth uh, evaluation of the patients and their families affected with genetic disorders. So from where Prajna stopped, that is, when you identify a syndromic child or a suspected genetic disorder, you have to do the confirmatory test to diagnose or confirm what type of genetic disorders you are dealing with. For that, the basic concept of what type of disorder probably we are dealing with, whether it is a chromosomal disorder, whether it is a monogenic disorder, whether it is a multifactorial disorders, or a mitochondrial disorder, or a somatic cell genetic disorder. It's a very basic concept of genetic disorders, because if you see a patient, for example, thalassemia or spinal muscular atrophy, which is a monogenic disorder, where we don't have to do any test for chromosomal abnormality, whereas a patient with a Down syndrome or Turner syndrome or a child with multiple malformations or autism spectrum disorder or intellectual disability, these type of patients, we are suspecting more of a chromosomal abnormality, where we have to do the chromosomal basis test, cytogenetic test, look for the abnormality. Whereas in multifactorial disorders like neural tube defect, isolated congenital heart disease, or polygenic disorders like diabetes, hypertension, asthma, etc., even though they are having some susceptibility to genetic disorders, we cannot do a karyotype. There is no meaning in karyotyping or a microarray. But there are some tests which can identify some susceptibility, which is not routinely practiced in our clinical practice. In mitochondrial disorders, you have to do separate mitochondrial DNA analysis. Somatic cell genetic disorders or cancers, where DNA testing or specific testing has to be done. So this is for the just for the introduction. So now today we are going to discuss only about the chromosomal abnormalities and what are the various tests which we will look for the chromosomal abnormalities. So first introductory slide for chromosomal abnormalities can be a numerical abnormalities like aneuploidy, where the number will be changes, like trisomy. Trisomy, commonest trisomy, as you know, is the Down syndrome, where there is a 21, chromosome number 21 will be 3. Whereas monosomy means there will be one chromosome will be less. That is, total number of chromosome will be only 45 instead of 46. Commonest cause, as you know, is the Turner syndrome, where one of the sex chromosome is lost. So it can be an aneuploidy, or polyploidy means multiples of chromosome. Instead of 46 chromosomes, there can be 69 or 96, something like that, but which is not compatible with life and usually will not come into the picture of a pediatrician or a baby with abnormality, but it will come during abortus material evaluation, or some you may get some reports saying that if there is some abortus material and you identify some polyploidy, how to counsel. But we are not going to tell and discuss detail regarding that, but it's extremely rare. And second option is there is no numerical changes. There are structural abnormalities. Total number of chromosomes is 46 only, but there can be part of deletion of the chromosome. Part of the chromosome will be lost, or part of the chromosome will be duplicated, or there can be translocation. That means one part of the chromosome is attached to another part, or there can be an inversion. That means there is two breakpoints between the two chromosomes and there can be change, or a ring chromosome or an isochromosome. So here it is a deletion. You can see that some part of the chromosome is lost. Here it is some duplication is there. Here you can see this translocation between two chromosomes. Here you can see that there is some breakpoint in these two areas. And instead of A, B, C, D, E, F, here A, B, D, C, E, F. This part is inverted. So these are various types of chromosomal abnormalities. And to identify these numerical and structural abnormalities, you require various types of tests. So this copy number variance, the terminology we usually use to describe a chromosomal abnormality, because copy number variance is another terminology we use where there is a multiple copy of a DNA, multiple DNA segments, a large number of DNA segments is one side it is lost or duplicated. So basically there is some extra copy or a minus copy. This copy number variants can be identified by karyotype, fish, and microarray and some of the recent tests. Whereas this right part of the thing showing some monogenic disorders, which I am not going to discuss today at all. Just I have narrated it to understand you that MLPA, Sanger sequencing, mutation specific testing, NGS, etc. is not the specific test for chromosomal abnormality. These are the various major techniques like chromosomal banding analysis or karyotype, or fluorescent in situ hybridization or chromosomal microarray. And optical genome mapping is the advanced technique which I don't think most of the pediatricians or clinicians will be using nowadays. So we are not going to discuss. It is a future test. It's available now in one of the research centers, but it is not routinely used in the clinical practice. Only in very rare situation you may have to use it. But routinely you should be able to give it. One is karyotype. If it is a genome-wide test, you require a viable cell, single cell test, resolution is low, sensitivity is 10%. Whereas if you go to the chromosomal microarray, which Minal is going to tell is a genome-wide with a very high resolution. So difference is between the resolution. Resolution means how minor variants also you can identify. That is the important thing. Fluorescent in situ hybridization is a targeted test. You will be able to identify only some of the specific micro deletions or micro duplication. In my presentation, I will show you the cases, then you will be able to understand. So this is the same which already we have described. It's a condition like Down syndrome. You know, it's a classical Down syndrome where you can see that there is an aneuploidy. 3 chromosome abnormality will be there, where you can do by a conventional karyotype, whereas it is a Williams syndrome where there is a micro deletion, where you can identify that micro deletion by a fish. And it is a multiple malformation where there is a small copy number variance which cannot be identified by a conventional karyotype or we don't know which area we have to test. Microarray has to be done, which will be dealt in detail in the second session of the same presentation. So there is a karyotype is there, fish is there, microarray is there. Okay, so just don't confuse. There are 3 terminology I have introduced to you. One is karyotype with low resolution, microarray with a high resolution. Karyotype and microarray is the whole targeted test, whole genome test, whereas fish is the targeted test. Okay, now we will go to the in detail about the conventional karyotype. A conventional karyotype and high resolution banding, usually we will look the metaphyse or a pro metaphyse. We will look at the microscope, light microscope, to analyze the chromosomal abnormalities. And in high banding, high resolution banding, resolution will be little bit better. But whatever you do, the maximum resolution will be somewhere around 3 to 5 MB. And this requires a dividing cells. That means in a microarray, it is actually a DNA-based test. So you can easily send the sample. Whereas in karyotype, we have to do the culture. So culture means cell has to grow. It should be a live cells. You cannot send to the lab and lab can do after 10 days or 15 days. The cells will die. So ideally, it should reach to the lab where karyotype is doing within
చెల్లె
24
కదా
hours.
ఇవ్వాలి చెల్లె కదా చదువుకో
Taking.
తర్వాత తీసుకోను
And another thing is you
చెల్లె
have
కదా
to do the
చెల్లె
culture
కదా పప్ప
and
చెల్లె
you
కదా
have to
చెప్తున్నా
arrest this in the
కదా
metaphase so that it may take about 10 days to do the karyotype.
చెల్లె కదా
So,
పప్ప మళ్ళీ తర్వాత
uh,
తీసుకోవచ్చు నువ్వు
which all situation we have to suspect a chromosomal disorder, like congenital global developmental delay, one or more major malformation,
పెద్దవాళ్ళు కదా
prenatal onset of abnormal growth pattern, craniofacial dysmorphism, unusual behavior phenotype. These are all situations where you have to look for the cytogenetic abnormality. That's like as a pediatrician, you know, so many patients you will see the intellectual disability with or without multiple malformation. So isolated intellectual disability or with or without a multiple malformation or even without a intellectual disability, if child is having multiple malformation, always a chromosomal abnormality has to be suspected. Then prenatal onset of abnormal growth pattern. That means if there is a significant short stature, significant failure to thrive, always we have to suspect the chromosomal abnormality. Then dysmorphic child. Previous day, you have discussed about lot of dysmorphism. It may be a classical syndrome like Down syndrome, or it may be an unusual phenotype, which you may not be able to identify. You have to suspect chromosomal abnormality. And similarly in autism spectrum disorder. What sample you will collect, because you have to collect the sample and send to the lab. It is only a venous blood. Anticoagulant used is heparin. That is the difference between a DNA test where usually we will use EDTA. So in a karyotype, always heparin, heparin, heparin. Quantity is 1 to 2 ml. No special precautions are required. Storage is 2 to 4 degrees centigrade. And transport preferably within 24 hours to the lab where it has to be done. And this is about the detail about the chromosome preparation. I don't think a clinician should know all these details, but they should know that it will take minimum of 7 to 10 days and usual turnaround time is around 21 days because it is a culture-based technique. Some people, preliminary people will feel that today I have given the blood, tomorrow or day after tomorrow, I should need the result. You will not get the testing or you will not get the results like that because you have to take a 5 ml venous blood, add 5 hemoglobin and culture has to be done. Culture at 37 degrees centigrade for 3 days. So first 3 days we lost in the culture. Then add colchicine and hypotonic saline, do cells fixed, then do the serial of washing. Then you have to take a pellet. That pellet has to be put into the slide from a height, a chilled slide. Then there will be a slide preparation will be there. And this slide has to be do the staining as well as banding. Then you have to analyze under the karyotype to look, identify the abnormality. So it is a little bit a cumbersome method. Expertise is required. More time is required compared to a complete objective result, which you are going to hear in the second part of the presentation. So what are the indications? Already I told suspected chromosomal abnormality. Just like if you clinically, I think most of the pediatrician can diagnose a Down syndrome, then you can directly go to a karyotype. Then unexplained intellectual disability is one indication for karyotype. But why I have put into the red is if microarray facility is available at present in unexplained intellectual disability and autism spectrum disorder, microarray is having a better clinical utility than karyotype. So if finance is not a major issue, I think in unexplained intellectual disability and autism spectrum disorder, if microarray is possible, that should be the first test before karyotype. But if microarray is not possible and karyotype is available in-house, you are justified in doing a karyotype to look for major abnormalities. Then disorders of sex development, because as you know, always sex development are classified based on the karyotype. It is 46XX DSD, 46XY DSD, or a chromosomal DSD. So the basic test for any child with a typical genitalia is karyotype. And all short stature prepubertal female, Turner syndrome has to be ruled out. For Turner syndrome, karyotype is the test, not microarray, because karyotype can identify the Turner syndrome as well as what type of Turner syndrome we are dealing with, what is structural abnormalities. Then in pregnancy loss and infertility, for reproductive counseling, always karyotype is the test of choice because we have to identify the balanced translocation carrier where we have to do karyotype only, microarray cannot detect. Then malignancies to look for various structural abnormalities. For example, in AML, we have to look for monosomy 7. In CML, we have to look for Philadelphia chromosome. All these situations, chromosomal abnormalities, karyotype and FISH is the test of choice. Aplastic anemia to look for breakage studies, karyotype is a test of choice. And in prenatal diagnosis, there are various indications where you can do the test, which I will come to that later. So now I will go for, I think time is less. I will just go through the various cases. So here you can see that Down syndrome, physical features of Down syndrome, brachydactyly, facial phenotype, small BSD. By looking at the child, you know that it is Down syndrome. You can see that there is 321 is there, which is easily confirming that. So whenever Down syndrome is there, first look at the position of 21. How many 21 is there? 321 is there. So it's a non-disjunction free trisomy, which is seen in 95% of the cases. But in all cases, it may not be there. Here you can see that there is only 221. So here it is a 1321 translocation. Here it is 1421 translocation. Here it is 2121 translocation. Here you can say that it is a ring chromosome. So various structural abnormalities can also come in the Down syndrome, which can be detected only by the karyotype, not by the microarray. So Down syndrome also, the test of choice should be the karyotype to look for various structural abnormalities also, which is important for the recurrence risk prediction. When there is a translocation Down syndrome, parental karyotype has to be done, then recurrence risk will be increased accordingly depending upon the type of translocation. This is another case where multiple malformation, polydactyly, cleft lip, cleft palate, micropenis. So here we have done the karyotype, we got the trisomy 13. By looking at the patient itself, we know that polydactyly, cleft lip, cleft palate, micropenis, most important possibility is trisomy 13. So you can do a karyotype. But even if you have done the microarray, you can pick it up. But sometimes some hospital protocols in multiple malformation, apart from Down syndrome, microarray may be the choice. That is, we cannot say a wrong thing. You can go to that. Then also you can detect it. Here, trisomy 13 is picked up by the karyotype. Here it's a Turner syndrome. First child is a 10-year-old girl with a short stature. I told you, every female with a prepubertal short stature, a conventional karyotype has to be done to rule out a Turner syndrome, which is important because we can do a lot of management like growth hormone therapy and other treatments. And Turner syndrome can present like hydrops fetalis, baby with typical phenotype features, short stature, primary amenorrhea, and infertility. All these situations, you have to do the karyotype to look for the testing. Here, just like Down syndrome, I have shown it is a 45X, whereas aneuploidy, one X chromosome is lost. It is, you can see the partial deletion. Here it is ring chromosome. Here it is an isochromosome. And it is a 36-year-old with a small size penis, hypogonadism. So any child with any adult with azoospermia, gynecomastia, infertility, hypogonadotrophic hypogonadism, sorry, hypergonadotrophic, I have a mistake, hypergonadotrophic hypogonadism, you have to suspect a Klinefelter syndrome where you have to do the conventional karyotype. Already I told classification of DSD, sex chromosomal DSD, XY DSD, XX DSD. So karyotype should be the first line of investigation for any patient with atypical genitalia. And coming to the other malformations like 5P deletion syndrome, it's a first child consanguineous marriage, failure to thrive, hypertelorism, retrograndia, cat-like cry. In this type of situation, we totally agree you can do microarray or a karyotype. Microarray will have a better utility, but these type of classical deletions can also be picked up by the karyotype. Here beautifully you can see that how the short arm of the 5P is lost. 5P deletion syndrome is there. Similarly, this is another child with the multiple malformation. where you can see that one extra material is the trisomy, 17. It's a normal chromosome 17. Here you can see that after this dark band, there's an extra light band is there. So there is some extra material is there. And when we have done the parental karyotype shows the balanced translocation from 8 and 17. Here you can see part of the 8 is lost. Here is 17 is extra. So in the parents, it is balanced. They don't have any loss or gain. But when the child born, it can be a partial monosomy 8, partial trisomy 8, or partial monosomy 17, or partial trisomy 17. So these type of parents can have increased chance to have recurrent abortions or children with abnormality or infertility. So here it is, this abnormality has been identified by the chromosomal abnormality, and parental test will help you to delineate what type of chromosome. Microarray can also be done in the baby to look for what is that extra material. Similarly, here is also another child with the respiratory distress, small for gestational age, cleft palate, congenital heart disease, and mother gives history of 3 first trimester abortion. So here we are expecting X chromosomal abnormality. You can do a chromosomal test or you can do a microarray, which explain will next time. So here you can see that we got a marker chromosome with extra material. By looking at the karyotype, we don't know from where it came, but microarray will help you to delineate which is that part. And so also it's also a complementary in some of these type of rare, difficult cases. Karyotype as well as microarray will be complementary. And the parents, mother has shown the uh, translocation between 11 and 22, which also explain her recurrent abortions. So this is a couple with the 3 first trimester abortion, where you can see that translocation between 4 and 9. Here is another couple with the abortion, where in a male, there's a translocation between 4 and 15. You can see the 4, you can see the 15. So in a couple with a recurrent spontaneous abortion or infertility, or a parents with a structural abnormality of any chromosome, that is a copy number variance of any chromosome, even if you identified by the microarray, parental karyotype has to be done to look for balanced translocation carrier. But when you do the karyotype, always you should know about the normal variants. This is another major area where people will confuse, because this is an inversion 9 where you can see that it looks like one extra material is there. So a beginner may see that there is some extra material that is contributing to the phenotype. But this is an inversion 9, which is a normal polymorphic variant, which is usually not associated with any phenotypic abnormality. So these type of normal variants has to be explained in such a way that it will not cause any phenotypic abnormality. It is only a polymorphic variance. These are the common polymorphic variants we will see in our population, like inversion 9, heterochromatin increase in length 16, satellites on 21, 22, 13, 14, and 15. These are all acrocentric chromosomes. Here also you can see one satellite in 14. You can see 14 chromosome if you see in this picture. This is the end of the chromosome. Here is also end of the chromosome, acrocentric. But here you can see that two antenna-like structures, these are satellites. These are all only ribosomal RNA, which will not produce any phenotypic abnormality. Similarly, Y chromosome sometimes will be very lengthy, which is no abnormality, which is actually an increase in heterochromatic region. Little bit expertise is required confidently to say that it is normal variant, but this is one area which is very, very important during counseling. This is another child with the 10-year-old child with thrombocytopenia, leukopenia, pancytopenia. Peripheral smear shows macrocytic anemia with thrombocytopenia, which shows that it is possibly we are dealing with a Fanconi anemia, where we have done a chromosomal breakout study, separate protocol with the mitomycin C. You can see that various chromosomal breakage, and chromosome has multiple breaks, and they have formed the triradius, quadriradius, etc., etc., which is the classical feature of a DNA repair defect. It is not exclusively for Fanconi anemia. It can be seen in Fanconi anemia, Bloom syndrome, ataxia-telangiectasia, etc. But this is the common situation, because in other Bloom syndrome and ataxia-telangiectasia, so many other phenotypic features will be there. You can directly diagnose. But in aplastic anemia, always we are having a confusion whether it's a constitutional aplastic anemia or acquired aplastic anemia. There are some clinical phenotype as well as hematological phenotype to help you, but still this can be used as a indicator to say that we are dealing with a bone marrow failure syndrome due to chromosomal breakage syndrome like Fanconi's anemia. Like prenatal sample, we can do by amniocentesis or CVS, and aneuploidy screening test high risk, antenatal detected malformation, previous baby with a chromosomal abnormality, and one of the parent with the balanced structural rearrangements. All these situations, chromosomal kininotype can be done from the amniotic fluid. But here there are so many intricacies is there, because if you do the microarray or a QFPCR, rapidity of the test, so many things are there. So I'm just, for a completion's sake, these are also the situation where chromosomal kininotype can be done. But nowadays, with a newer and newer test, sometimes kininotype can be replaced by other newer tests. But kininotype can be done in here also. But there are a lot of limitations for kininotype, like resolution is limited. I told you only 5 to 8 MP. Test needs actively dividing cells, labor intensive, turnaround time, required skilled personnel, and telomeric regions abnormality cannot be identified. So there we required an advanced test where smaller abnormalities can be identified. There can be targeted test or a whole region test. Whole region test will be discussed later. In a targeted test like microdeletion syndrome, like Prader-Willi, Angelman, Miller-Cardiofacial, Williams, Miller-Dicker, this type of situation, we know where will be the microdeletion. So since we know the specific area where there will be a deletion of the segments, we can directly do the fish. For example, here you can see that the child is having a conotruncal anomalies referred from Sri Chitra with some facial anomalies. So we know that we are dealing with probably a DiGeorge syndrome. We want to rule out a DiGeorge syndrome. DiGeorge syndrome is a situation where there is a deletion in the 22q11 deletion. So we know particular area is deleted. So we are having a specific probe, fluorescent probe for that area. So in a karyotype, it's a karyotype only. In a karyotype, we will do a fish. So in a normal fish, you can see that these are the 222 chromosomes. You will get the 2 green signals and 2 red signals. And these red signals are the areas where 22q is deleted. That is a specific area for 22. The green signals are for the control probes. Because if there is some extra washing had occurred or a result testing was not properly occurred, we will not be able to identify the 22 chromosome where it is there. So to identify it and make it a control probe, these green probes are another area in the another area of the 22 chromosome. So this green area is there. So its result is perfect. 22 chromosomes 2 is there, but 122 probe is there. Another area, that area is deleted. That is 22q11. That some area is deleted. So this confirms the diagnosis of DiGeorge syndrome. So for the DiGeorge syndrome, we don't have to do the entire microarray. If you are suspecting that, clinically you suspected that, directly you can do the fish test. Similarly, in Williams syndrome, another common syndrome. These are the 2 common syndromes, DiGeorge syndrome and Williams syndrome, where there is 7q11.23, where we can do the fish testing. Fish testing can also be used for the malignancy, where already I told you, there is a 2211 translocation, some of the other, so many translocation with the prognostic indicators for various malignancies. We can do the fish testing because it's a target test to identify a chromosomal abnormality, which can be a deletion or a duplication or a translocation, etc. But nowadays it is a little bit limited because cost is a little bit high. A subjective expertise is required. Cumbersome test. Only in very specific, very rare situations or in some research setup, usually fish is do because we are having a more better and easy tests are available. The modifications of fish can be done for a pan specific. I told you it's a targeted fish, but there are some spectral kinenotyping or a multiplex fish, etc., where all these chromosomes can be colored. Here you can see that one of our case where there is an extra material in the chromosome number 30. We know from where it has come. We have done it has done in our collaborative lab, that is in the RCC Regional Cancer Center. They are having spectral karyotype for one research purpose. So this case we have done. Nowadays we will not do that. We will just do the microarray easily. We can identify. We don't require it, but it is an important test in some rare situation where this can be identified. This is one of our case where we can identify. You can see this color is equivalent to the 18 color. So which has shown that it is a 13-18 translocation. So this type of some complex translocation, complex structural rearrangement, fish will help you to delineate. Similarly, fish can also use for the rapid interface fish. So this is my last slide. So whatever I have done, I have told, this is everything has been written in the IJPP article also. There is a stewardship, rational use of genetic test in Indian Journal of Practical Pediatrics in 2023, I think. So there I have given the entire table for both cytogenetics as well as the molecular. But here I have taken only that. So very simple. A pediatrician, if you see the Down syndrome, Turner syndrome, Klinefelter syndrome, you have to do the conventional karyotype. And a parents of a child with the chromosomal abnormalities, coupled with a recurrent pregnancy loss, infertility, we are suspecting balanced translocation carrier, conventional karyotype. Whereas in microdeletion syndrome, clinically diagnosed, like DeGeorge syndrome, Williams syndrome, or in the case of rapid aneuploidy testing in prenatal sample, you can use a fluorescent in situ hybridization. Multiple malformation, intellectual disability, and nonsense spectrum disorders. Nowadays, microarray is the preferred test, but microarray is not available. You can use the conventional karyotype. Microarray details, next speaker will inform you. Thank you. Thank you very much for patient listening. I am here for answering any question. Rachna, I think I have completed.
Thank you so much, Shankar sir. That was a wonderful talk, and you've highlighted all the important aspects of cytogenetic testing, the principles, the technique, the applications, and the interpretation. We'll take the questions after the second talk is over. If the audience have any questions, queries, please type them in the chat box and we'll take them up in the end. We now invite Dr. Meenal Agarwal. Dr. Meenal, can you please start sharing your slides? So, our next speaker, Dr. Meenal Agarwal, is head of the Department of Medical Genetics at KEM Hospital, Pune. Dr. Meenal?
Yeah, Pradnya, I am looking to from where I should be sharing. I can't see the prompt to share my video, share my presentation.
The small green thing at the bottom, share. You're not able to see that?
Mhm. No. Yes, now I can see. Yeah. Is somebody already sharing their screen? No. Okay.
Dr. Shankar has stopped sharing his.
Okay,
Yeah,
now?
now it's visible. You can put that in the slideshow mode.
Yeah.
Yeah, thank you. So Dr. Meenal is head of the Department of Medical Genetics at KEM Hospital, Pune. She is also director of clinical and she is adjunct faculty in the Department of Reproductive Genetics at Kasturba Medical College, Manipur. She was formerly faculty at SGPGI Lucknow as well, and she's one of the founder members of the Indian Academy of Medical Genetics. So she has a lot of expertise and experience in performing, analyzing, and interpreting results of complex high genomic tests, including microarray, next generation sequencing, and exome sequencing, and genomic variants and in genotype phenotype correlation. She has more than 40 publications to her credit, as well as 4 book chapters. So we would really like to thank Dr. Meenal for accepting our invitation today. And over to you, Dr. Meenal. She'll be talking to us about chromosomal microarray, the applications, the interpretation, and the utility of this test in pediatric practice. Thank you, Meenal. Over to you. Meenal? Meenal, you're not audible.
Dr. Sridhar, are you available? Dr. Sridhar or Mr. Satish?
సార్ ఐఎమ్ హియర్
చూడండి అది
సార్
చూడండి
సార్
ప్రాబ్లం
నా నుండి డిస్కనెక్ట్ అయిపోయింది సార్ డ్యూ టు ఇంటర్నెట్ ప్రాబ్లం ఉండొచ్చు సార్ మళ్ళీ రీజాయిన్ అయితే మేక్ ఏ కోపోస్ట్ సార్
Dr. Meenal, can you rejoin?
She is probably trying to rejoin, sir.
Okay.
But Shankar sir, it was an excellent presentation with clarity and authority, with wisdom. We really 20 or 25 minutes just passed away like that. I hope Dr. Shankar sir is there.
Can you hear me now?
Yeah,
Yes, yes,
yes.
we can hear you.
Was I audible in between? No, I lost my connection.
Yeah, previously when you had started screen share, yeah, now we are able to see your screen, your slides.
Okay, sorry for that glitch. Okay. So we will
Now
just
it's
take a
okay.
couple
Yeah,
of.
Dr. Meenal, you
Okay,
can continue. We are able to
all
hear
right.
you and see your slides. Thank you.
All right, Dr. Pratnya, thank you. So from a couple of slides, a quick recap, and then we will start from where exactly Dr. Shankar stopped at karyotype and fish. So for a general pediatrician, each one of us is developing from a single cell, that is a zygote. And zygote in turn is formed by the union of two cells, one sperm coming from father and one egg from mother. And at that point of time, half of the genetic material is coming from each side, that is 23 chromosomes and about 25,000 genes residing on those chromosomes. And it is expected that 50 to 80% of those early embryos are abnormal, and that is mainly chromosomal. But in fact, 2 to 5% of every life-born child is expected to have a major genetic disorders because errors can happen anywhere. So when I talk about genetics, what comes to our mind? Each human body is composed of billions of cells of different types, and all of these cells are originating from a single cell, which is zygote. Inside each of these cells, there is a nucleus where 23 pair of chromosomes, 6 billion alphabets, or a pair of 25,000 genes, and that makes a complete genome. And whether we are testing for a chromosomal disorders or we are testing for a single gene disorders, we need a different testing camera, as Dr. Shankar was describing. If you are looking for a panoramic view, we need a different camera setting. If you're looking for a targeted and a very high resolution, we need a different type of camera setting. And there are somewhere in between as well. So karyotype is very equivalent to the low resolution panoramic view of genome, while whole genome sequencing is a very high resolution, but still gives you each information of all genome. All molecular tests, apart from karyotype, they start from DNA, and the DNA comes from the nucleus, from the nucleated cell. And the typical source of DNA which we used in our clinical practice is from leukocyte from blood. And that DNA is then can be utilized for array of genetic testing, which you have been hearing for past 4 or 5 sessions, like PCR, like MLPA, like microarray, like next generation sequencing, so on and so forth. So one haploid genome means that half of the genome which is coming from one parent has 23 chromosomes. Together, they are about 25,000 to 30,000 genes. And they are composed of 3 billion base pairs, which are in pairs. You can imagine a large encyclopedia, which has 6 billion alphabets, 23 volumes, and about 25,000 chapters. And if you look for a one chromosome may harbor about 1,000 to 2,500 genes and about 10 to 130 million bases of alphabets. And alphabets, the genomic language is only AT and GC. The karyotype, which you heard in the previous talk, can look at a resolution for at least one dark or light band located on our chromosomes, which is composed of at least 3 million such base pair and maybe up to 25 to 75 genes. So imagine if you are looking for a one alphabet change in the entire encyclopedia, the karyotype may not be the best option, like Dr. Shankar was telling, like for thalassemia. Other single gene disorders like cystic fibrosis, like inborn error of metabolism.
వాడు కాదు ఏమంటుందండి
you need a separate testing to look for that single alphabet change. So hence, we have heard that resolution of karyotype is less. This is a very powerful slide which tells us about the resolution of testing. We were here. So karyotype can look for the missing or the extra chromosomes, that is maybe a few million base pairs, or a minimum of one light and dark band, which is about 3 to 5 million base pair. Another thing you must be aware of sequencing technology, which can look for a single or few alphabets at a glance. But in between, there are three kinds of tests, basically FISH, MNPA, and microarray, which can fill the gap between the karyotype and the sequencing technology. We have already heard about the FISH. I will touch base about MLPA and will describe in detail about cytogenetic microarray. So these tests like MLPA, cytogenetic microarray, and FISH, they look for a specific type of genetic abnormality, which are known as copy number variants. I'll take a minute to describe that. So what are copy number variants? Copy number variants are genomic segments. You can imagine a number of, paragraphs or statements or the lines, which are at least 1,000 alphabets long. That is 1,000 base pair or 1 KB at a stretch, but it may go long to a few million base pair. In fact, a chromosomal aneuploidies or extra chromosomes or a missing chromosome are technically a large copy number variation, which is in short is called as CNV. The other important thing is they are submicroscopic because their size is less than 3 to 5 million base pair. They are submicroscopic. They are not visible in karyotype because they are less than one white or dark band. And in that dark band, there can be one genes, there can be many genes. In one genes, there can be a complete gene or a partial gene, one exon, few exon. So it depends upon the size of that segment. Another concept to understand that we have 23 pair of chromosomes, and on that 23 pair chromosomes, there are about 25,000 genes. And for that 25,000 genes and other genomic segments, we have two copies, one coming from mother and one coming from father, except for the regions located on X chromosome in males, because males have only one X chromosomes. They are called as hemizygous. They are not having two copies of that genomic segment. So if there is a one copy more, it becomes 3. So it becomes a gain of genomic segment. And in a genetic language, we call it as a duplication. And because they are submicroscopic, they are typically called as microduplication. If there is a one copy less, it means there are one copy. There is a loss of a genomic segment and there is a deletion. And because this is a submicroscopic, in genetic language, we call is a microdeletions. So CNVs are microdeletions or microduplication, depending upon one copy is extra or one copy is missing. Mostly the disorders caused by these copy number variation are caused by one extra copy or one missing copy. These are heterozygous. They are mostly dominant, but there have been rare scenarios where one copy of the chromosome is bearing deletion and the other copy is having the other genetic variation and thus making a genetic disorder, a recessive condition when both the copies have to be mutated. How can this cause a genetic disorders? Looking at the first picture, we have a chromosomal pair and there is a segment which is less than one white or dark band, which cannot be visible in karyotype. So there are two genomic segments, one coming from father and other coming from mother. If there is one extra segment on one chromosome, this becomes an heterozygous genetic variation. And because this is a gain, this becomes a heterozygous duplication. And the total number of that genomic segments or copy number variation becomes 3. In case of deletion, out of 2 chromosomes, only 1 chromosome is bearing that copy. Either this is caused by a dosage effect of the gene where exactly 2 copies are required to maintain a normal function. If the copy is less and gene is sensitive, this becomes an haploinsufficient genes, means less copies are producing an abnormalities. Or it can be a triplosensitive where extra copies of the genes are abnormal. More than this, they can cause a disruption of the gene, so they can lead to a malfunction of a gene, or it can be an unmasking a recessive allele. So if there is a genomic segment deletions or duplication on one chromosome and a small sequence variation on the other part of the chromosome, this may present as an autosomal recessive disorder. So after FISH, the second technique which looks for this copy number variation is another molecular cytogenetic technique, which is MLPA, which we will break it up. This is a multiplex ligation dependent probe amplification. So multiplex means it can look for a 60 chromosomal segments in a single reaction, as compared to FISH, which can look for 3 to 5 segments for the identifications of these CNVs. So MLPA has a larger multiplexing capability. Probe amplification. So here the probes are identified, which are artificially manufactured, and they are specific to a specific genomic segments in the genome. And the amplification dependent on hybridization and ligation. And that's why multiplex reaction, ligation dependent, this is dependent on the ligation of the probe and the probe amplification, and we are amplifying the probe. And the results are represented in the semi-quantitative manner from mainly 0 to 2. So if the ratio is equal to a normal DNA, that should be 2. So 2 in control, 2 in test. So then the ratio should be at 1. So all probes are showing at the ratio of 1. This is a normal result. But if 1, 2, or more multiple probes, look at the red dots in the picture, they are having one copy deleted. It means one copy in the test control, two copy in the controls. That becomes half. So the ratio becomes 0.5. So this is a deletion, micro deletion, which is in the deletion of one copy of that genomic segment. If the genomic segment is one copy extra, that is a gain or a duplication, then you can see the ratio of these genomic segment as 3, because the control has 2 copy, the test has 3 copies, the ratio becomes 1.5. So these are as example of heterozygous duplication. So there is a various advantages of MLPA because 60 segments can be interrogated in one reaction. And this is very versatile. It can look for one exon of a gene to a whole chromosome like in aneuploidy. Certain imprinting disorders like Prader-Willi-Engelmann syndrome, Reckitt-Wiedemann syndrome, methylation-specific MLPA or MS-MLPA has a specific advantage because it can look for methylation abnormality as well as copy number abnormalities. In certain conditions, single gene disorders, deletions and duplications are major cause of a genetic disease. In those cases, tests like karyotype or microarray will not help, and the MLPA is the test of choice, like spinal muscular atrophy, like Duchenne muscular dystrophy, 30% cases of CYP21 age-related congenital adrenal hyperplasia, alpha thalassemia. 90% of cases are caused by deletions, which can only be picked up by MLPA. And we have heard that karyotype is very labor intensive, takes about 10 to 14 days, and it is expertise dependent. MLPA takes about 2 days time to report, so it can be used for those testing as well. But it has certain disadvantages as well. It can only look for up to 60 genomic segments in one reaction. Second most important disadvantage is it's always targeted. Ready-made kits are usually used in the reaction and they might not be available for a disease, and this might not be cost-effective for a single sample. Like you heard in previous lecture, that if you have a direct clinical suspicion of a microdeletion condition like Prader-Willi syndrome, like Williams syndrome, like velocardiofacial syndrome, you can use FISH. Before the advent of microarray, MLPA used to look for 45 or 60 genetic condition in one reaction, but now it is superseded by the most advanced test, which is cytogenetic microarray, to look for genome-wide, phenotypic agnostic copy number variation, and we will discuss in a bit. So there are, in past 1.5 decades, there are many microdeletion syndrome has been discovered. We know that Prader-Willi-Engelmann syndrome is 15q region. Velocardiofacial is 22q1 1.2, and you have seen the cases of 4p minus, 5p minus. So FISH or MLPA can be done only for a specific number of targeted region. But if you have so many conditions and so many microdeletion duplication syndrome which are discovered in 1.5 decades, which overlapping phenotype, FISH or MLPA might not cover everything. And as a clinician, you might not remember every specific condition related to a specific genetic condition. And hence, in 2010, the consensus statement was released and cytogenetic microarray was proposed as a first-year clinical diagnostic test for developmental disabilities for congenital anomalies. and which increases the diagnostic yield from 5 to 6% in karyotype and 10 to 12% from in MLPA, up to 15 to 20% in cytogenetic microarray, which is shortly called as CMA. So what are the major advantages of CMA over other molecular cytogenetic tests? Number one, it is across genome. There is no customization required, and one testing platform is being done for each individual. This is phenotypic agnostic. Most of the times, you do not have to have a clinical suspicion. Whether you have a Prader-Willi syndrome in mind, whether you have a DiGeorge syndrome in mind, Williams syndrome, or any child with facial dysmorphism, developmental delay, multiple formation, where you are suspecting a chromosomal abnormality, CMA is the test of choice. The resolution of karyotype is about 100 to 1,000 times higher than the karyotype. Karyotype can look for a 5 million base pair, and it can look for 1,000 base pair or 1 kilo basis. The starting material is DNA, and that's why no culture is required, which is a major drawback for the karyotyping testing. And hence, chances of failure of culture were less, and it was typically proposed for the testing like products of conception, where culture failure was as high as 30 to 50% with inability to produce any results. And as I discussed, that the use of CMA as a first-year test for unexplained developmental delay increased the diagnostic yield from 5 to 6% in a routine karyotype to 15 to 20% by cytogenetic microarray. Some technical jargon, you might not remember everything, but a crash course will be helpful to understand the reports. So chip. So the karyotype is done on a slide and a microarray is done on a chip. Only the slide size is less and the resolution is much higher. This is about 1/2 inch into 1/2 inch long, and there are millions of spots are there where the probes are spotted, means the known string of oligonucleotides, they are spotted on each such position, and they are targeted to a specific genomic segment. The DNA, which is a test DNA, which is again added to that chip, and that gets hybridized to these specific spots. And based on the signal generated, the intensity of signal generated, the copy number is computed. It is 1, 2, or 3, which is the case in most of the times. Another technical jargon which we need to understand, it is the SNP array, which is the oligonucleotide array. It's just the way our probes are designed. Probes is nothing but a string of a nucleotide, which is spotted on a slide, and the computer knows that to which genomic segment it is targeted to. So if it is targeted to a single alphabet in the dictionary of a 6 billion alphabets, it becomes an SNP array. And if the probe is targeted to the string of alphabets in the genome or a string of nucleotide in the genome, it becomes an oligonucleotide array. To provide the best sensitivity and specificity, usually a combination of SNP array and oligonucleotide array is used. Second term we need to understand is the high resolution versus low resolution. It all depends upon the camera setting. How have you set your camera to provide a low resolution image or a high resolution image? Obviously, the high resolution camera will have high pixels. So the high resolution microarray will have the higher number of probes, the background in the genome, as well as to the targeted regions. And the resolution, based on resolution, you can use the testing platform in your clinical setting. So various array platforms which are used in clinical setting are Affymetrix, Illumina, and Agilent, with Affymetrix is most worldwide, most commonly used. So 315K or low resolution means in that chip, about 315,000 spots are there. In the high resolution, 750,000 spots are there. And there are more higher tests which are not generally used in the clinical setting. So based on the experiment, the DNA is added to the slide, and based on the signal intensity, the copy number is generated. Either you get a deletion or you get a duplication, as we have already heard. And this is called as a CNV, a copy number variation. So if the copy number variation is identified, what is next? So each one of us is likely to harbor a few CNVs, which can be a genomic variants, which is normal to our population or our family. And some of them may be a disease causing. If this distinction that the CNV or a genetic variant being normal to my family, my personality, or my population is not disease causing, it is called as benign. And these are not reported. But some of them may be a disease causing, which is called as pathogenic or likely pathogenic. And pathogenic means there is a more than 99% certainty that a particular CNV will cause a disease. A likely pathogenic means there is a more than 90% certainty that a particular CNV will cause a disease. And in a clinical context, the utility of likely pathogenic and pathogenic CNVs are similar. But in between two extremes, there lies a big chunk of the variation where currently 30 to 40% of genomic laboratories are reporting variants of uncertain significance when we are not certain whether this is a disease causing or not. And there is more than 90%, the range, the chance of pathogenicity may differ from less than 90% to more than 90%. So if you have identified a CNV, what does the lab do next? So depending upon the certain characteristic, the laboratory tries to identify a CNV into a benign or a pathogenic or a clinically relevant variant. And this typically depend upon it is a deletion or a duplication event. For the gene where one copy is not sufficient to produce a normal phenotype, this becomes more likely pathogenic. These are haploinsufficient gene where insufficiency of a gene copies are not likely to produce a disease. Then the size of the event. The size of the event means size of that paragraph missing or paragraph extra may range from 1,000 alphabets to the millions of alphabets. So depending upon that size, larger the size, higher is the chance to that CNV becoming a pathogenic or clinically relevant. And the CNV, the content of the CNV, it means what genes are lying in that region, what functions do they have? Do they have a dosage sensitivity like one copy less or one copy extra is going to cause a disease? What is the predicted functional effect? If it has been reported in a normal population or it has been reported in a diseased individuals, or what is the family segregation? It means if a variant is classified as an uncertain significance and it is inherited from one of the parent, it is more likely that the variant is not having a disease phenotype, though we have certain nuances to this because of the age-dependent penetrance, reduced penetrance, variable expressivity, but we are not discussing those complex scenarios in today's presentation. But when this distinction between the benign and the pathogenic is not clear, the CNV is classified as variant of uncertain significance. There are certain discussions globally going around if we can classify these VUS to further subcategories, like possibly benign or a cold VUS, possibly pathogenic or a kind of a warm VUS, or typically VUS which lies exactly in the middle. But currently, subcategorization is not being reported. And here, the clinicians input, the evolving phenotype, and the family segregation study function analysis come into this picture. So how do we collect this evidence? The collect evidence basically from the published literature, available databases, in-house database of that laboratory, and the segregation analysis. Typically, across all labs, 80 to 90% of the samples are easy, straightforward, where the laboratory identifies a clear-cut benign variant, which is very common across population, or there is a diagnosis of recurrent deletions or duplication, which are already well-established microdeletion duplications syndromes. But rest 10 to 20% of cases, the variant is not classified as benign or pathogenic, and then we have to look for the clinical phenotype. As a clinician, I would suggest to look for that CNVs and its effect, the genes located in this region, and so on and so forth. Decipher, DGV, and PubMed are the databases which will provide you information whether that CNV is reported in a normal population. In that case, it becomes less likely pathogenic or towards slightly benign. Or if it is reported 1 or 2 times in a affected individual, but we don't have enough evidence to classify it as pathogenic, then it becomes like an hot VUS or towards slightly pathogenic. And the UCSC browser gives you all the gateways to these softwares and in-house and databases as well. The Franklin and Wasome are 2 freely available software for majority of the cases, where if you put your CNV information, it will give you a quick view what evidence does it have, whether it is reported in the normal population or not. So this can be a quick way in your clinical setting when you are looking at the report and you want to check whether it is, or it is an old report, you want to check the recent classification, so on and so forth. So to give you an examples how the classification of this CNV is done. So look at these segments. The segment is containing gene 1 to gene 6. And out of these gene 1 to gene 6, only gene 3 is known to have haploinsufficient. Meaning, rest of the genes, we do not have information that one copy of the gene is enough to maintain a normal state or not, but only gene 3, if the one copy is less, or there is an deletion, or there is an heterozygous deletion of the gene, it is known to produce a phenotype. And the red lines in the first half of the image can be CNV1, CNV2, 3, 4, 5, 6, and 7. So you can see in the second image that the CNV5 and the CNV6 are not involving the gene 3, which is known haploinsufficiency. It means that even if a person is harboring a deletion in the same region, the specific genes is not located in that region, and that becomes not pathogenic. So only CNV1, 2, 3, 4, and 7 are pathogenic because they are incorporating a gene which is known to have a dosage sensitive. So like this, there are a very 4 or 5 stepwise semi-quantitative scoring method, which is developed by Klingen and ACMG. And that is globally, universally classify a CNV, but there can be some subjective variations here and there for the classification of variant of uncertain significance. And hence, being a clinician, it's important to understand those. A couple of examples. So this is a typical example where we will employ a cytogenetic microarray technique, 2 years, global developmental delay, facial dysmorphism, cleft lip, cleft palate, high resolution 750K FE matrix is the test of choice for such scenarios, and it was offered. And it detected, now probably you understand these terminologies. So 1 million base pair, 1 MB deletion means a heterozygous loss, which was having a gene which was haploinsufficient in ADNP, where loss of function are associated with a known syndrome. And because it was harboring a gene which is known to have a phenotype, this was classified as pathogenic. Another scenario, hypotonia, failure to thrive, non-specific facial dysmorphism, lysencephaly, subcortical band heterotopia. And there, though the deletion size was much smaller than the previous case, it had a gene PAFAH1B1, which is known to have lysencephaly, and hence this CNV was classified as CNV. But sometimes the cases, most of the times, the cases are not straightforward, which you see in the clinical practice. So this case, which I saw some time back, non-specific global developmental delay, microcephaly, epilepsy, non-specific facial dysmorphism, spasticity. This was an old case where the easy, cost-effective testing like whole exome sequencing was not available. So we went for an inherited gene panel that tested for 550 genes at that point of time. And that detected 2 variants in a gene, that is PCCB gene, which is associated some inborn error of metabolism, propionic acidemia. But because the child's NBS profile was not matching with this, the variants were classified as uncertain significance. We did not stop at there. And then we had the availability of cytogenetic microarray, and it showed 2.9 million base pair deletion. And at that point of time, this was in 2011 or 12, when it was not very well characterized region as a microdeletion syndrome. So what we did was we studied the genes located in this region, and there was a gene which had FOXG1, and a couple of publications were there where deletions in this region were associated with developmental delay, microcephaly, corpus callosum abnormalities, and some syndrome-like features. We compared the facial features of our child and other publications, and we felt that some of the facial phenotype were matching with the cases described in the literature. And based on this evidence, the variant of uncertain significance was reclassified as likely to be pathogenic. Though there is no curative treatment available, the prenatal diagnosis can be offered to this family. Another important concept which we need to understand in the microarray data is loss of heterozygosity. So I'll go a little slow on this slide because this is an important concept to understand. So again, each one of us has 46 chromosomes in each cell. There are 23 pairs inherited from each parent. And these 23 pairs have 6 billion alphabets, 3 billion alphabets in pair. So at a particular location, if the alphabet is same, A, T, C, and G, this becomes a homozygous. If that alphabet is different from that specific position, this becomes an heterozygous. So in CMA, the probe is placed at at a regular interval. So you can see that in the entire encyclopedia of 6 billion alphabets, you are interrogating one alphabet at regular interval. So if the stretch of probes at a different alphabets, they are the same, it means this is a stretch of homozygosity, or in genetic terminology, we say it is a loss of heterozygosity. Another terminology which is used to describe the same phenomena is absence of heterozygosity, region of homozygosity, ROH, or long continuous stretches of homozygosity, that is LCS. It does mean just at a continuous stretch, the CMA probes, the spelling is same, the nucleotide is same. And it is also called as copy neutral loss of heterozygosity. What does that mean? That the copy remains same, the copy remains 2 or diploid or euploid, and the specific nucleotide or alphabet is seen. So it can be just by chance, because the nucleotide or alphabet can be just same at one position. That is because of identity by state. And in all individuals who are tested, if the size of that contiguous segment is less than 3 million base pair, we say that, okay, this is mostly because of a chance phenomena. But what happens in consanguineous families when you are likely to inherit the same genetic segment from both the parents? It is usually more than 5 million base pair, and total segment all over the genome will be more than 2 to 3%. Another scenario when you will see such phenomena, when instead of one chromosome coming from each parent, both the chromosomes are coming from one parent, that is a uniparental disomy, and which can express itself into imprinting disorders. And in this case, you will see the whole chromosome, or more than 10 to 15 million base pair on a single chromosome, the stretch of nucleotide. And it is also because if you are inheriting both the copies from the one parent, it has the potential to unmask imprinting disorder or autosomal recessive disorder, where the present allele has the pathogenic variation. So this is in homozygous region, uniparental disomy. All CMA reports, they mention about ROH or LOH regions, but typically not highlighted in the region. And these are important to look at in the certain scenarios. And just example. So this case had, the family was non-consanguineous family. Previous child has neurofibromatosis, which was, the mutation was identified and the variant was not segregating in either of the parent. It means it was a de novo case of neurofibromatosis. The doctor, the fetal medicine expert, offered the prenatal testing in the next pregnancy of the mother. And as a NF1 mutation was absent, but as a routine offering, the family was offered a microarray testing. In the microarray, there was no significant copy number variation, but there are this about a 3 million base pair LOH region on chromosome 15. And the doctor felt that it is not important, and pregnancy was continued. The child was the pregnancy had some polyhydramnios and antennae, and I saw this child in the ICU with the poor activity, hypotonia, not gaining weight, so on and so forth. And then I had a chance to look at this report, and then I realized, okay, this region was overlapping with Prader-Willi syndrome or Angelman syndrome, which was clinically correlating well with the phenotype. And it was a kind of a clinically confirmed diagnosis of Prader-Willi syndrome. And for that, the confirmatory test was MSMLPA, and which confirmed the diagnosis. So if the LOH region is lying in a genomic segment where it is known to have an imprinting disorders or a condition where it can represent in the methylation abnormalities, it may be important to look at those regions. Coming on to 2 slides about how to read a report. So in the typical report there, you will see a typical segment. First is the clinical details of a patient and the clinical history, and then the type of the array which has been performed and the nomenclature. So now we will break it up. So in the nomenclature, you will see such kind of a statement, which is a global universal. So ARR, array stands for array. GRCH38 is the version of human genome to which your genetic test has been compared. You can analogously compare to the different edition in the library. The 22 is the chromosome number. Q stands for long arm, and subsequent number is like the specific position on the chromosome where that segment is lying. Long arm, region, band, subband, sub-subband, so on and so forth. For example, if you want to locate a book in a library which is huge, you have to know the lane number, the shelf number, and the serial number. Same way, to make it as a universally and globally acceptable, the CNV has to be marked at which position in the genome it is lying and into one. Into one means that instead of two copies, there is a one copy. It means this is the deletion, and one copy of this segment is absent. And because of the size and the region and so on and so forth, this CNV has been classified as likely pathogenic. So every testing has limitations. So does CMA. So sometimes a clinician can have a confusion whether which platform we need to select for a specific scenario, and we will talk about it. There can be a difficult interpretation of variants of uncertain significance, especially in the prenatal scenario. There can be nuances like incomplete penetrance, variable expressivity. So even if it is inherited from one of the parent, it might be important. And sometimes cost in Indian scenario may be an issue. It does not identify origin of marker chromosomes and low level of mosaicism in some cases. And very important, what you heard in previous lecture, it will not identify the balanced chromosomal rearrangement, which is the test of choice in couples with infertility and unexplained pregnancy losses, where karyotype is the only test of choice. Microarray application in parents with infertility, couple with infertility or pregnancy losses has no use because it will not detect balanced chromosomal rearrangement. What is the current indication? So it is the first or the second tier test along with the next generation sequencing based assay for unexplained developmental delay, malformation, autism, dysmorphism, intellectual disability. It is a test of choice in the case of major prenatal ultrasound malformation, like brain malformations, heart malformation, so on and so forth. Should be offered to all women undergoing invasive testing for any reason because the background chance of identifying any significant copy number variation can be up to 1 to 2%. Diagnostic yield in the prenatal setting where ultrasound has detected a major malformation or multiple malformation may be up to 30 to 50%. But we need to understand there is a 2 to 3% chance of identifying VUS as well, which pose diagnostic dilemma and reproductive decision. If this is a missed miscarriage, POC, and early pregnancy losses, low resolution microarray should be good enough. Pregnancy with malformation, high resolution microarray, or a stepwise manner with WES. Child with developmental delay, AS, autistic spectrum disorders, malformation, high resolution microarray, together or in a stepwise manner of whole exome sequencing. And it has a limited role in the regression of milestone or suspected metabolic disorder, where we suspect single gene disorder, which are better interrogated by the sequencing technologies, basically NGS-based exome sequencing platform. So these are one of the last slides. So this is a genome-wide test aspect to targeted in FISH and MLPA. You are likely to get surprising, unexpected, uncertain, incidental, non-matching phenotype, and this poses a diagnostic dilemma, especially in a prenatal setting. Clinical significance depends upon the clinical presentation, age, penetrance, and expressivity. Pre-test, post-test counseling is utmost importance. Take assistance from your genetics colleagues in VUS or unmatching phenotype. And parental segregation is important, but is not an obvious step. And you have to choose your reliable lab partners. Thank you so much. And I'll stop here and we'll be happy to take any questions.
Thank you very much, Dr. Meenal, for that extensive, elaborate, and wonderful talk, highlighting all the important aspects of chromosomal microarray. I thank both the speakers for today, Dr. Shankar sir and Dr. Meenal. And if there are any questions, we'll be happy to take that.
I think there are no questions in the chat box also, madam. So,
Okay.
yeah. So, sir, Bhaskar sir, any closing remarks?
Yeah. Once again, the way the speakers had presented, the participants had no questions. I think they had acquired the thorough, complete knowledge. I don't know about that. But we being practicing pediatricians and pediatricians, uh, definitely we could pick up some points wherein we should detect early and refer them to the geneticist or to the Department of Genetics. That is the concept of this entire webinar series. And the talk by Dr. Shankar VH was very excellent, very useful to the practicing pediatricians. And thank you, Dr. Meenal Agarwal. It was a little high-end, probably useful to the residents of genetics and even to some of my colleagues who are very sound in the knowledge of genetics. My sincere thanks to you for sparing your valuable time on this holiday. Same applies to our convener, Dr. Prajna Ranganath. So thank you all the participants, and over to Dr. Sridhar and to the speakers
Yeah.
to make any closing remarks.
Thank you much, sir. And thank you, Prajna madam, for doing a wonderful job. And thank you, Minal Agarwal and Shankar sir, who had done a great job in this. And hope next genetic webinar will be with a new topic and new rising. So thank you, one and all, sir. Thank you. Thank you.
Yeah.
Thank you.
Thank
Dr.
you.
Shankar, do you have
Thank-
any closing remarks from your side?
Yeah.
Yeah,
Please.
Oh,
please.
Thank you, Prajna. Actually, that questions, I think in genetic seminars, I think last for so many pediatric forums we are discussing, questions usually will not come because they will be hearing it and they will be just awareness creation is the most important thing. They may not be able to ask. Otherwise, it should be a pure clinical like dysmorphology or genetics. They may have some doubt. This is always they will have doubts that their questions may be they will ask by wrong intention. They will doubt like that. But I also expected like that only. So it is not a problem, but definitely it will create a awareness among the clinician, saying that this type of different tests are there. At least they should be able to know that I should have some thinking of what test I should send before a genetic testing. It is not a just like hemoglobin DC, take a sheet of paper and write it. It should not be like that. There are so many intricacies are there. I have to think about it. If I have should write it, I should learn it. Or otherwise, as you know, it's are told, refer to a geneticist where a better testing, proper testing can be done. So, possible ways, try to learn more. Or otherwise, identify it, refer to a geneticist. But nowadays, genetic testing is mandatory. Confirmation of testing is important. Just branding will produce Cori. For so many years, the patient will have some brand. Actually, it may not be the disease itself. That's all.
Thank you, sir. Thank you so much. Thank you, Bhaskar sir. Thank you, Dr.
Thank you.
Sridhar.
But
Yeah.
Dr. Meenal may
Thank
have
you.
some because Dr. Meenal may have some remarks.
No,
Yes,
I
ma'am.
think thank you, Dr. Pratnya and team IAP for giving me this opportunity. I think, as Dr. Shankar said, we have been trying for past more than 1 decade to create awareness. And now it's a time when everybody knows that it is important, it has to be done, but the correct kind of an application and the utility there is still some lacuna. And that's why we are trying to fill that gap. So take assistance from your genetics colleagues whenever required. That's all. And thank you, Dr. Pradnya, for taking this effort to giving pediatrician this platform to understand this technology. Thank you.
Thank you, Dr. Meenal. Thank you so much.
That's great. Thank you, ma'am. Thank you so much. Thank you, sir.
Yeah.
Can leave the things. Thank you.
Dr. Prajna may say something.
Oh, no, sir. That's all, sir. So please do join us for the next session. That will be in the on the first Sunday of June, and we'll have many more interesting talks, sessions covering the other important aspects of genetics over the rest of the year. Thank you so much to IAP Telangana PATS
Oh,
for
thank you.
this